So my disclosures, and again, this is just reminding everyone of the point that in the era of PSMA PET, we're discovering men with metastatic disease who in conventional imaging had negative imaging, and we're treating as localized disease, sometimes as intermediate risk disease. So when we think about shifting this to an advanced disease cohort, we really have to keep in perspective the excellent outcomes with conventional treatment for a large cohort of these patients. And again, the other point here is, obviously PSMA, we've been talking about at all conference, quite revolutionary for assessment of prostate cancer patients. For men with clinically localized high-risk disease, it's only about 40% sensitive for nodal disease, about 95% specific for nodal disease. So that relatively weak negative predictive value, 81%, means that many patients with negative scans and high-risk clinical features will still have positive lymph nodes. So that is from the de novo newly diagnosed population. So we cannot use today a negative PSMA to dissuade us from a node dissection for clinically localized high-risk patients. Similarly, at PSA recurrence, when we see a positive node, we know from the salvage node dissection literature, it usually is the tip of the iceberg, as was summarized earlier. Normally, when we do a salvage node dissection in that setting for one positive lymph node, we will have 3 to 5 pathologically positive lymph nodes in that region. So it's underrepresenting the volume of disease in a recurrent setting. So really important when we're interpreting PSMA scans, and we'll hear more from Dr. Koo in a minute, the pretest probability of disease, newly diagnosed versus recurrent, the role of prior treatment, all very important in interpreting the scan. So when we think about androgen deprivation therapy with or without radiation, getting to this treat the primary for node-positive disease, there's some retrospective data that I think is interesting. And this is a little bit of an older study now, but reviewed NCDB patients from 2004 to 2011, looked at hormonal therapy alone versus those exposed to hormonal therapy plus radiation. Because of all of the challenges of retrospective reviews, there was a propensity score matching of 318 patients. And it showed that the patients who had hormonal therapy plus radiation had a significantly lower risk of 5-year all-cause mortality. And all-cause mortality is very important in this setting because you got to make sure that whatever therapy you're measuring prospectively or retrospectively isn't just treating the prostate cancer and then contributing to all-cause mortality. So the summary of this retrospective review was there appeared to be value to treating the prostate node-positive disease. One of our outstanding faculty at UCSD, Brent Rose, did a nice analysis of the VA database. And again, this is clinical node-positive, non-metastatic prostate cancer diagnosed between 2000 and 2015 based on conventional imaging from the VA. And we compared prostate cancer-specific mortality and all-cause mortality between treatment groups using multivariate analysis. And basically, the group that got hormonal therapy and radiation of the prostate had improved prostate cancer-specific survival. And interestingly, when we looked at the entire cohort and dichotomized the cohort by the mean PSA of 26, we looked at the lower risk group versus the higher risk group. That lower risk group seemed to benefit from local treatment. This is a theme that gets repeated as was just reviewed in Stampede. But when you look at the entire cohort of node-positive patients, there didn't seem to be value to treating the prostate. And interestingly, hormonal therapy was also associated, and radiation was associated with improved all-cause mortality among the men with the below median levels. Now, there's nothing magic about a PSA of 26. That's happened to be just the median of this cohort that allowed us to dichotomize the population. And these are the curves of prostate cancer-specific and all-cause mortality for the patients with a PSA under 26. Again, this is the entire cohort on the right, that prostate cancer-specific mortality, no different for the whole cohort. So the conclusion of this study, hormonal therapy and radiation better than hormonal therapy alone for node-positive prostate cancer patients. The interaction was strongest for patients with a PSA under 26, may not be the optimal cut point. That happened to be just the median of the population. So we repeated this database looking for men who'd had a radical prostatectomy. And there was only 78 men in the national VA database who had clinical N1 disease and a radical prostatectomy diagnosed in these 15 years among the 741 men who were clinically node positive by conventional imaging. And again, when we looked at surgery versus radiation with hormonal therapy versus hormonal therapy alone or observation, and we did similar all-cause and cancer-specific mortality analysis. We found that non-definitive therapy was inferior to either surgery or radiation, but there was really no difference between the radiation and surgery, likely because of the very small n. But prostate cancer-specific mortality and all-cause mortality for those who had their prostate treated was significantly better. Now, why does this look better than a well-designed randomized trial? Probably because there's significant selection biases. The patients who we choose to treat locally are almost certainly healthier, more robust. There's a reason in a retrospective review that they're likely going to be doing better, no matter how well you control for multivariate analysis. Again, this is the curves from that study, just showing that no separation between surgery and this is radical prostatectomy versus non-definitive therapy, showing a benefit to radical prostatectomy at the top. And then at the bottom, trying to compare surgery and radiation and hormonal therapy, we could not see a difference. So again, this was just summarized the Stampede trial. And again, over 2,000 men, newly diagnosed M1, randomized to hormonal therapy versus hormonal therapy and radiation. Very high-risk cohort. Probably this group, look at the median PSA 97, so probably be interesting if you did PSMA scans retrospectively on this group. I wonder whether the low-risk metastatic group versus high-risk would change with more sophisticated imaging. But in any case, 40% had the definition of low metastatic burden, 54% high metastatic burden. And again, as was reviewed, the radiotherapy improved failure-free survival, but not overall survival, and radiotherapy was well tolerated. The pre-planned subgroup analysis revealed patients with low metastatic burden did benefit from treatment of the primary. And again, as was correctly summarized by Dr. Hahn, this is really level 1 evidence, although because of the nature of the pre-planned analysis, but because this did not meet the overall goal of the trial, there is still some equipoise in this space and these ongoing clinical trials that he summarized. This is the overall survival in the top curve, the failure-free survival in the bottom curve of the whole cohort. And again, if you look at overall survival upper left, that is low metastatic burden. Overall survival in high metastatic burden, no benefit to treating the primary. Failure-free, low metastatic burden, quite a benefit. But again, failure-free in high metastatic burden, no benefit. So this is now in the guidelines. If you look at this year's guidelines, ADT plus radiation to the primary tumor for low metastatic burden M1 is in the guidelines as a standard of care for M1 castrate-sensitive prostate cancer. So when we look at lymph node positive prostate cancer after radical prostatectomy, again, this is a different cohort. This is not N1 at diagnosis. This is N1 at surgery. I think this is still the largest retrospective series looking at the management of a large cohort of node-positive patients, over 1,300 node-positive patients after surgery from 3 large centers. About 28% of the patients were observed. About half received lifelong adjuvant androgen deprivation therapy, and I agree that's likely over-treatment in many of these patients. And 23% received radiation therapy and hormonal therapy, and the primary retrospective outcome, overall survival, secondary outcome, cancer-specific, and other cause mortality. And what you see here, the green line is radiation and hormonal therapy. The blue line is ADT, and the red line is observation. And again, if we look at cancer-specific survival on the right and overall survival on the left, it looks like either hormonal therapy or hormonal therapy and radiation do better. And what was really interesting about this trial, again, this is the hazard ratio, overall survival, ADT versus ADT and radiation, and again, showed that ADT and radiation patients had a much lower recurrence risk, and cancer-specific also very similar. But one of the interesting things is lifelong hormonal therapy was a risk in this trial. And the surprises from this excellent retrospective analysis is many patients with node-positive disease did very well. Treated patients had 75% cancer-specific survival at 15 years, but lifelong adjuvant ADT was associated with an increased risk of death from other causes compared to observation, hazard ratio of 3. So putting people on lifelong ADT, like the Messing trial suggests, probably is putting them at higher risk for overall mortality at the same time that we're improving their cancer-specific mortality. So higher risk patients appear to do better with hormonal therapy and radiation. So these are some summaries that have already been summarized with the intermittent ADT plus radiation for oligometastatic disease, so I won't repeat that. So in summary, I think there's value to treating the primary and T3 and N1 prostate cancer. There's value to treating the primary with radiation and low metastatic burden M1 disease. The threshold of metastatic burden is not well known. In Stampede, it's less than 4 sites of metastases. In our retrospective studies, it's below a PSA in the 25 to 30 range. A great clinical trial is underway that we're accruing to, looking at the impact of radical prostatectomy and radiation in this M1 population. That's the SWOG trial, 1802, led by Dr. Chapin. Pathologic N1 patients benefit from salvage IMRT and ADT. I observe pathologic N1 patients to try to give about a third of those patients do well with no recurrence. So I try to give them a chance to not recur and avoid therapy. About 2/3 will recur and need therapy, and I do radiation, recommend radiation and hormonal therapy for those patients. And we're learning about METS-directed therapy. Early results of phase 2 trials are favorable. That's it for me.